Hello, and welcome to the CHEST Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Alice Gallo Moraes.
Hello and welcome to another CHEST Journal podcast. I am Alice Gallo, an intensivist at Mayo Clinic in Rochester, Minnesota, and today I'm going to talk to Dr. Sato about his paper on mortality in patients with sepsis treated with Esmolol or Landiolol, a systematic review and meta-analysis of randomized controlled trials with trial sequential analysis. Dr. Sato, thank you so much for being here and welcome to the podcast.
Yeah, it's a great pleasure to be here to discuss our studies. Thank you for inviting us.
Thank you so much for being here. So to start, tell our listeners about a regular day at work for you in beautiful sunny Hawaii and what inspired you to update this meta-analysis.
Of course. I'm working as a critical care physician in Hawaii at the Queens Medical Center, and I usually work in the medical ICU and the mixed ICU, medical surgical ICU, and the cardiac ICU. I practice on also ECMO as well. Through my clinical work, we often get to see the patients who has been tachycardiac, even after addressing some of the factors affecting heart rate, for example, things like fever or hypovolemia or, agitation or pain. Those are pretty common to cause tachycardia. But even after addressing all these, we often get to see people still has persistent tachycardia in the clinical practice. So the initial question was why? And then soon, we found, it's likely to be a result of oversympathetic tone or overstimulation of sympathetic tone, or maybe in other words, maladaptive, tachycardia. So I think, these people tends to receive a lot of catecholamines externally, but also internally, they have a lot of excretion of catecholamine in the body. And some of the studies, even though those are observational studies, suggest that too much catecholamines or higher vasopressors or catecholamine dosage are associated with worse outcomes. Though it might reflect, just simply the shock was worse enough to get, receive the high dose, vasopressors. But in my mind, maybe blocking certain receptor may actually work. And then that's the beginning of this question. And then we knew back in 2013-14, there was one paper published in JAMA about use of Esmolol in the context of the septic shock. Actually, that showed drastic change in the mortality. So that was the beginning of, investigating this clinical question. In fact, I think, we did a meta-analysis back in 2020, which showed significant mortality benefit. But as all of you know, there are more studies coming out this year, last year. And that's why we felt, it's needed to reevaluate this clinical question because that could be very relevant to our patient population.
Yeah. And your original meta-analysis also had less patients than this one that you included, right?
Correct.
Yeah.
And in the critical difference between our original meta-analysis and this updated meta-analysis is this meta-analysis only included a paper published in the English journals, but written in English. But the original paper included all studies in any language. But there was always a question about whether this finding is generalizable to any population or the studies that was included in the original meta-analysis are all small, relatively small. So those are something that we had to overcome. And then we thought, okay, maybe adding multi-center RCTs, which was published after the original meta-analysis, will help to overcome, generalizability of the finding of the original meta-analysis.
Yeah, the original meta-analysis were mostly from Asian countries, right?
Correct. And in fact, I think about the half of the RCTs were from China, and those are single center RCTs. So when it comes to if it's applicable to any other countries or any other settings, we still had to investigate further to evaluate, to see if that's really applicable to the other settings.
Yeah. So you updated your meta-analysis from 2020 basically with the same questions, just with newer studies. So tell our audience about what were the questions that you and your team sought to answer.
Yes. So after adding the multi-center RCTs, our question was whether Esmolol or Landiolol can improve mortality in the context of sepsis with tachycardia. That was the biggest question. And second question is, how does it affect the hemodynamics? For example, things like heart rate, cardiac output, or stroke volume, or even blood pressure or norepinephrine dosage. And we knew some of the data were going to be limited. So when we started this project, we were not too sure if we can really update the findings of these, hemodynamic parameters because of the lack of the data. But those are the questions that we raised. So the original question was whether those medication can improve the mortality in the context of sepsis with tachycardia.
Yeah. And tell me then about the PICO question that you used to frame the studies that you were included in this updated meta-analysis.
Of course. So the patient population is the adult, patients equal to or older than 18 years old with sepsis. And typically sepsis defined by the accepted definitions such as sepsis 1, sepsis 2, or sepsis 3. Mm-hmm. And intervention is Esmolol or Landiolol. And compared to placebo or none, and the outcome is mortality. And one of the differences from the original meta-analysis for this study is we use the longest mortality available. So some of the studies reported 90-day mortality instead of 28-day mortality. So we picked longest mortality instead of just focusing on 28-day mortality. But also, we did a same analysis on 28-day mortality as well. So those are the outcome for the primary outcome. Yeah. And secondary outcomes included hemodynamic parameters such as heart rate, norepinephrine dosage, and our plan also included stroke volume and the blood pressures if it's available.
Yeah, that's awesome. So tell our listeners what you found.
Yeah, so we found sort of a mixed results. The primary analysis showed non-significant effect on the mortality by using the Esmolol or Landiolol. However, we noticed there is a tendency to lower the mortality, though there is a little bit of a caution to interpret this study. So the statistical significance wasn't reached, but all analysis that we did had some tendency to improve the mortality with Esmolol or Landiolol. But that was not statistically significant. So we did a sensitivity analysis as well, based on if it's a single center or multi-center, or if it's above median mortality or less than median mortality. And Also, we did a trial sequence analysis as well to check the robustness of the study. And as you probably saw, there was a mixed data. And our conclusion was probably a study result is not robust enough. And TSA, the trial sequence analysis, even suggested number of patients, needed to make a significance is probably far more than what we have. So one of the findings tells us that basically we need more studies on this topic.
I agree. One of the hardest things is to decide, right, at bedside, if you have someone like severe sepsis, septic shock, when to slower that heart rate, because it might be that it's just the heart really trying to keep up that cardiac output, right?
Yes. And that's why in our paper, we actually suggested, when we are using this medication, at least we should have some sort of information about cardiac index or cardiac output or stroke volume.
Yeah, I was hoping you could talk a little bit more about that. So your recommendations also like to use serial, perhaps point of care ultrasound at bedside to also check cardiac output when rapid beta blockers are given.
Yeah. Yes. Because beta blocker can impact on the hemodynamics in either way. If diastolic dysfunction is significant and then patient needs a feeding time, that could potentially increase the stroke volume. However, if it's still compensatory tachycardia, the beta blocker can actually has a detrimental effect.
Yeah.
So before and after starting the beta blockers, I would recommend to check at least cardiac output using at least serial echocardiography. Ideally, in the ideal world, maybe we might better to have a pulmonary artery catheters. However, the routine use of pulmonary artery catheter has a lot of barriers and other aspects of, for example, a chance of getting complications, stuff like that. So I think at least serial echocardiography or some information about cardiac input or cardiac outputs are necessary to safely use beta blockers.
Yeah. So has anything changed in your practice in your ICU since you share your data with your team?
Yes. So I personally has been using Esmolol when tachycardia is refractory, and I'm sort of sure this is not compensatory. However, like I said, usually I do a bedside ultrasound echocardiogram and obtain the BTI and calculate the cardiac output. After starting Esmolol with the lowest dose, I usually check VTI again and then calculate the cardiac output and then make sure it's not significantly dropping. If heart rate is successfully coming down without compromising cardiac output, then we can gradually titrate the medications. That's how I do. And I'm sort of an interesting person because I have experience to practice in Japan, and Japan has a Landiolol. So I do have both experience of using Esmolol and Landiolol. And both are very similar. Landiolol has a little bit of shorter half-life and maybe a more pure beta-1 selective, beta blocker. So it has less impact on the beta blood pressure. But same thing, we should use echocardiogram to check the BTI and monitor how it affects the cardiac outputs before and after the beta blocker.
So is that what you would recommend to our listeners who are pretty positive that their patients are not having this tachycardia for compensatory reasons only and want to use a rapid onset beta blocker to then calculate cardiac output, cardiac index with an echo plus minus a PA catheter?
Yes. I think if they were to use Esmolol or Landiolol, that would be something that probably everybody should think about. On the other hand, my caution to the readers of this paper is it's still not statistical significant, which means, it's not proven. So despite, I guess, although this is not contraindication, in my opinion, I think when people are thinking about using a beta blocker, we should be very careful. And I do think, differentiation of patients who might benefit from beta blocker from who has compensatory tachycardia is not easy. And then we have to kind of have some sort of a checkbox. This is not fever. This is not from pain. This is not from vasoplasia. This is not from, for example, hypovolemia. So we kind of have to go over all these and make sure it's not compensatory. And that's the hardest, part of this study.
So hard. So hard.
Yeah. And we do think, it might have affected the difference in the outcomes between single center and multi-center, because most of the study using Esmolol were from single center in this meta-analysis. And most of the study that used Landiolol was from multi-center RCTs. And if you see the patient's number, sample size for each multi-center trial, really, several patients, maybe in some studies, only 1 or 2 patients included per center, which means, you have done it only once or twice, as opposed to the single center, which has basically 40 to 150, cases per center, which is a lot. So I think, experience of, using this medication may make a difference. And then, when it comes to where it's coming from, I think the monitoring of hemodynamic parameters are a critical part of it, because many of these single centers actually reported hemodynamic parameters, such as cardiac output or stroke volume. And those are reported in the single center RCTs, which means they were routinely checking these, parameters when they're using it.
So they were using beta blockers for the patients who actually were gonna benefit from beta blockers.
Right. And then, it depends on the studies, but some of the studies used, PA catheters, some of the studies used echocardiogram, I believe. But, they had hemodynamic parameters information before and after using the beta blocker. So that might make a difference. Of course, that is something that we have to investigate in the future.
Yeah. So sounds like what we can say currently is that for the right septic patients, beta blockers very likely not harmful, can potentially help if we are using for the right patients.
Right. That's exactly the accurate statement, I believe. And then differentiation of that population from patients with compensatory tachycardia is still the question, $1 million question that we have to ask.
Yeah. So call for action from our listeners to work on that research.
Yeah.
Dr. Sato, any other findings from your study that you would like to make sure that our listeners pay attention to when they're reading your paper?
I think, as I mentioned a little bit, as far as we have as a data, the use of Esmolol or Landiolol didn't impact on the cardiac output for most of the studies that had a positive effect. So which means stroke volume has increased, but then heart rate decreased. As a result, cardiac output didn't change. That's the ideal effect of using the Esmolol or Landiolol by improving cardiovascular efficiency. And I believe in that case, ventricular arterial coupling is also improved with the beta blockers.
Yeah.
And then again, I would put strong emphasis on the importance of finding the right patient for this intervention, because this is still not proven strategy, and I would not recommend to use these medications as a routine practice. It's more for very specific population, and then for the right selected patient. So yeah.
Awesome. Thank you so much for talking to me, and thank you so much for sharing your results and your methods and your inspiration for your study. To the CHEST Journal Podcast listeners, I had the pleasure of talking to Dr. Sato about his study on mortality in patients with sepsis treated with Esmolol or Landiolol, a systematic review and meta-analysis of randomized controlled trials with trial sequential analysis that you can read at the CHEST Journal. Again, I'm Alice Gallo. I'm an intensivist at Mayo Clinic in Rochester, Minnesota. And on behalf of CHEST Journal, thank you so much for listening.